All right, welcome everybody to the Neurocritical Care Pharmacy Section Journal Club. My name is Corinne Berger and I'll be one of your moderators for today. I'm also joined by Leslie Hamilton and Casey May. Leslie is currently at a stroke, possibly pushing tenecteplase, so we'll excuse her if she's a couple of minutes late. And we do have two fantastic presenters with us as well. So we have Dr. Sarah Bittner, who is a critical care resident at Intermountain Medical Center, and Dr. Jennifer Stein, who's also a critical care pharmacy resident at Tufts Medical Center. So I just want to remind everyone, please, to mute yourselves during the presentation. That way there's no distraction. And then Casey is going to be moderating for us on Twitter. So please feel free to follow along on Twitter or X, hashtag NCSPharmJC. We'll do questions after each presentation, so you're welcome to just throw those into the chat box as the presenters are speaking or at the end, or you can just unmute yourself and go ahead and ask your question. And so with that, I will stop sharing my screen and I'll let Dr. Bittner take over.
All right, are you seeing my correct screen?
I am not seeing anything yet.
Not seeing it. Okay, give me just a moment. Are you able to see it now?
No, I don't see anything on my end. Casey, do you see anything up?
Still no slides on the screen?
No, I don't see any slides.
Sorry for the troubles. Give me just a moment.
Something's working now.
Are you able to see the correct slides now?
Yes, we do. We see it in presenter mode, just as an FYI.
Are you able to see the correct slides now?
Yes, perfect. Thank you.
Okay, sorry about the technical delays. My name is Sarah Bittner, as she mentioned, and I am a PGY2 critical care pharmacy resident at Intermountain Medical Center, which is a level 1 trauma and comprehensive stroke center in Salt Lake City, Utah. And today I will be discussing the early versus late anticoagulation for stroke with atrial fibrillation, or ELAN trial. Just some background about my presentation before I get started talking about the actual trial. I wanted to talk about the importance of the question that was asked in our study. So direct oral anticoagulation, or DOACs, as I'll refer to them, are highly effective secondary prevention after ischemic stroke or transient ischemic event for the prevention of recurrent stroke in patients with atrial fibrillation. However, there is still uncertainty that remains about their safety of early initiation of DOACs in this patient population regarding their risk of causing hemorrhagic complications. So our optimal timing to reinitiate these agents after an acute ischemic stroke remains an area of interest, as the risk of recurrent stroke is highest if you hold off on reinitiation, whereas the risk of hemorrhage may be highest within the first few days after acute ischemic stroke. And the randomized controlled trials that got DOACs approved, so our RELY, our ROCKET, and Aristotle trial, all excluded patients with recent acute ischemic stroke. So the current available guidelines that are pertaining to the topic of timing of reinitiation of anticoagulation in these patients with atrial fibrillation include the AHA and ASA 2021 guidelines for prevention of stroke in patients with stroke and transient ischemic attack, as well as our European Stroke Organization guidelines that were published in 2019 for the antithrombotic treatment for secondary prevention of stroke and other thromboembolic events in patients with stroke or transient ischemic attack and non-valvular atrial fibrillation. In terms of the recommendations of these guidelines, the AHA and ASA guidelines make suggestions for patients with high risk of hemorrhagic conversion that it may be reasonable to delay our oral anticoagulation beyond 14 days to reduce the risk of intracranial hemorrhage. This is the class 2A recommendation. And then in our patients with low risk of hemorrhagic conversion, they state that it may be reasonable to initiate our anticoagulation from between 2 and 14 days in order to decrease our risk of recurrent stroke. And this is a class 2B recommendation. In our 2019 European stroke guidelines, they don't actually make any recommendations about the optimal timing for initiation of anticoagulation treatment in our patient population with atrial fibrillation, based on the lack of evidence based on our randomized controlled trials. However, they do say that the following is reasonable. If a patient has a mild stroke with small infarcts, they say that it may be reasonable to start within 3 or 4 days. In patients with moderate infarcts, it may be reasonable to start our anticoagulation at day 7. And in patients with large infarcts, it may be reasonable to delay your anticoagulation for at least 14 days. Before I discuss the ELAN trial, I wanted to mention the 2 pieces of existing literature that discussed the similar topic, which are the TIMING and OPTIMIST trial. The TIMING is timing of oral anticoagulant therapy in acute ischemic stroke with atrial fibrillation. And our OPTIMIST trial is optimal timing of anticoagulation after acute ischemic stroke with atrial fibrillation. The TIMING trial is a multi-center randomized blinded non-inferiority trial that randomized 888 patients within 72 hours of onset to either early, which they defined as less than 4 days from the stroke, or delayed, which they defined as 5 to 10 days from the event, DOAC initiation. The study included DOACs apixaban, dabigatran, edoxaban, rivaroxaban, and warfarin. However, majority of the patients in the study, 62% in early and 49% in the late group, received apixaban, with the next highest being about 30% of both patient populations receiving warfarin. This study found that early initiation of the oral anticoagulants was non-inferior to delayed initiation with regards to their primary outcome, which is the composite of recurrent ischemic stroke, symptomatic intracerebral hemorrhage, or all-cause mortality at 90 days, with their primary outcome occurring in 6.8% of patients in their early treatment group and 8.6% of patients in their late treatment group. Our second trial is the OPTIMIST trial, which was a multi-center blinded non-inferiority trial that is still occurring and is randomizing patients within 96 hours of their event to either early DOAC initiation, which they are defining as less than 4 days from the event, or delayed, defined as 7 to 14 days from their event. Since this trial has not yet been published, data is not available regarding the specific oral anticoagulants that are utilized. However, it appears that they're including patients on all DOACs. And their primary outcome is a composite of recurrent stroke, systemic arterial embolism within 90 days, and is estimated to be completed in August of 2024. However, again, both of these are non-inferiority trials. That brings us to the trial that I'll be discussing with you today, which is the ELAN trial, early versus late anticoagulation for stroke with atrial fibrillation. Our authors were the ELAN investigators. The journal was the New England Journal of Medicine, and this was published in June of 2023. And our funding was the Swiss National Science Foundation. However, they did make note that funding bodies had no role in trial design, the collection, monitoring, analysis, or interpretation of the data, and that the writing of the manuscript was independent of funding bodies as well. So in terms of how our trial was designed, this was an international multi-center open-labeled randomized controlled trial that had blinded outcomes. The investigators included patients with acute ischemic stroke, which they defined as evidence of acute cerebral infarct on MRI or CT, or patients who had clinical symptoms of stroke that lasted greater than 24 hours and was confirmed by a CT or MRI that ruled out any sort of other cause. And the patients also had to have atrial fibrillation that was permanent, persistent, or paroxysmal, but not due to any sort of reversible cause. The study allowed the use of IV thrombolysis or thrombectomy prior to randomization. However, they excluded patients that were on baseline anticoagulation that had severe renal impairment, which they defined as a creatinine clearance of less than 50, who had serious bleed within the last 6 months, or had a high risk of bleed, which they defined as patients with active peptic ulcer disease, platelet count of less than 10,000, or a hemoglobin less than 10 with documented hemorrhagic tendencies. They did not, however, define serious bleed in the last 6 months. Patients were included from 103 sites in 15 different countries. In terms of our stroke classification, they were classified based on infarct size, which was determined by the site investigator using a standardized visual rating scale. The authors chose to use imaging-based definition of stroke severity based on the alternative being our NIHSS scores, being dependent on both the location as well as the size of the infarct. And several prior studies have concluded that the size of the infarct measures the volume, what measured by volume analysis, has been related to the risk of our hemorrhagic transformation. So really looking at the risk of bleed in this patient population. Authors classified our minor strokes to be those cerebral infarcts that were less than or equal to 1.5 centimeters, moderate to be infarcts that distributed to cortical superficial branch of the mid, anterior, or posterior cerebral artery, and major to be in those infarcts that were greater than 1.5 centimeters or distributed into the brainstem. So our participants in this trial were randomized 1-to-1 with a centralized web-based system to receive either our early or our late treatment. And they were the randomization was stratified based on their age, their infarct size, their NIHSS score, as well as their trial site. And then patients were assigned to either our early treatment group, which in patients with minor or moderate stroke, that meant that they were receiving their DOACs within the first 48 hours. Or if they had a major stroke, they were receiving their DOACs 6 to 7 days after their initial stroke event. In our later treatment group, patients with minor strokes were randomized to DOAC initiation at day 3 or 4. Those with moderate strokes received their initiation on day 6 or 7. And patients with major stroke had their DOACs initiated on day 12, 13, or 14. They included any DOAC that had a marketing authorization for prevention of stroke and systemic emboli in the trial site and at the approved dose in that country. For our primary outcomes, our primary outcome was a composite of recurrent ischemic stroke, systemic embolism, major extracranial bleeding, symptomatic hemorrhage, or vascular death within 30 days. And our secondary outcomes, which were assessed at both 30 and 90 days, included major extracranial bleed, symptomatic intracranial hemorrhage, recurrent ischemic stroke, systemic embolism, vascular death, and non-major bleed. In terms of our analysis, the primary analysis was based on a modified intention to treat due to one trial site being excluded after utilizing incorrect enrollment. The analysis of adverse events according to our treatment was the analysis of adverse event was according to the treatment that the patients actually did receive. And they calculated that a total of 2,000 participants would need to be included in order to achieve power. Our primary outcome was analyzed utilizing a penalized logistic regression model, which is a logistic model that accounts for low event rates by shrinking our coefficients of less contributive values towards zero. This is also referred to as regularization. So in terms of our results from this trial, there were 1,006 patients randomized to our early treatment group and 1,007 patients randomized to our later treatment group. Authors did not report any statistical significance of the differences among baseline characteristics. However, overall, baseline characteristics were well matched between the two groups, with median age being 77 in our early treatment and 78 in our later treatment group, and majority of patients in both groups being both male and of the Central European region. In terms of some other pertinent baseline characteristics, our pre-stroke modified Rankin scale scores were low in both groups, with majority of patients in both groups having a score of either 0, 1, or 2. When categorized by our infarct size on imaging, majority of patients in both groups had a stroke that was classified as either minor or moderate. At randomization, our NIHSS scores were low, with the median being 3 in both our early as well as our later treatment groups. And then this final table includes baseline characteristics that I will share regarding information about subsequent VTE prophylaxis, as well as medications that they were receiving at screening, and then the type of DOAC that the patients were receiving during their randomization. Of patients that were receiving VTE prophylaxis, the majority of patients, with 78.4% in our early treatment group and 77.4% in our later treatment group, receiving low molecular weight heparin. However, there was no data available regarding the timing of our VTE prophylaxis with respect to randomization or with respect to the administration of our direct oral anticoagulants. At the time of screening, 45.4% of our patients were receiving aspirin, and 54.1% in our late treatment group were taking aspirin. The doses of aspirin, however, were not specified. Less than 10% of patients in each group was on some other sort of antiplatelet medication, with clopidogrel making up over 90% of the other antiplatelets. When broken down by which DOAC patients received, majority of the patients in this trial were on apixaban in both groups, with 62.6% and 60.9% in the early and late treatment groups, respectively, receiving apixaban. So now we'll get to our outcomes of our trial. The primary outcome, again, was a composite of recurrent ischemic stroke, systemic embolism, major extracranial bleeding, as well as symptomatic hemorrhage or vascular death. And this occurred in 2.9% of our patients in the early treatment group, as well as 4.1% of patients in our later treatment group. The odds ratio was 0.7, with our 95% confidence interval being 0.44 to 1.14, with the adjusted risk difference being negative 1.18. Our other outcomes listed on this screen are all components that went into the primary outcome. All individual events favored our early treatment group, except death from vascular cause, which occurred in 1.1% of patients in our early treatment group and 1% of patients in our later treatment group. Overall, you'll see that symptomatic intracranial hemorrhage only occurred in 2 patients in both out of 1,000 in both our early as well as our late treatment group. However, our recurrent ischemic stroke occurred in 1.4% of patients in our early treatment group and 2.5% of patients in our later treatment group. While this difference was not statistically significant, it is nearing statistical significance, favoring our early treatment group, again, without that increase that we were nervous about with the risk of intracranial hemorrhage. These are the results of our outcomes at 90 days. And the results have only increased slightly from 30 to 90 days. Overall, our primary composite outcome was reduced in the early treatment group compared to our late treatment group, though again, not statistically significant. Clinically, it appears that our outcomes favor our early treatment group. None of the primary or secondary outcomes had statistical significant differences based on their risk difference or odds ratio at 30 or 90 days. And results of the primary and secondary analysis in our per protocol population were very similar to those that were seen in our main analysis. There was one subgroup that looked at the results of our primary outcome based on the country that patients were located in. And they found that there was a statistically significant difference in patients of Japanese descent of our primary outcome, with it occurring in 3% of patients in our early treatment group and 10.8% of patients in our late treatment group, making it evident that early treatment may be more beneficial in our patients of Japanese descent. Another subgroup analysis that I'd like to discuss is the results that you'll see on this slide are at 30 days. And you will see that the primary outcome mostly favored early DOAC initiation, specifically in our patients with high NIHSS scores, patients that are over 70 years of age, those with major infarcts based on the size of imaging, and female patients. This is the same subgroup analysis that was performed at 90 days. And again, you will see slight improvements in our same groups, the patients with NIHSS scores greater than 10, patients who are 70 or older, those with major infarcts based on imaging, as well as our female population, favoring early DOAC administration. In terms of our safety events that were reported in the trial, there was no statistical analyses that were performed on safety events. However, our safety events had similar rates between both groups. You'll see that any adverse event occurred in 47.1% of patients in our early versus 53.3% of patients in our late treatment group. And they broke that down into our serious adverse events, which was 13.9 in our early versus 15.8 in our late treatment groups. Again, no statistical difference was reported. And then in terms of our other outcomes, very similar between our two groups. So this brings us to our conclusions. So in this study, the authors concluded that the incidence of recurrent ischemic stroke, systemic embolism, major extracranial bleeding, symptomatic intracranial hemorrhage, or our vascular death at 30 days was estimated to range from 2.8 percentage points lower to 0.5 percentage points higher with early rather than later DOAC use, essentially stating that although they did not meet statistical significance, there was a trend towards improvement when DOACs were initiated at that earlier mark. In terms of critiques and relevance to our clinical practice, so there was no bias identified in the title, abstract, or with the authors of this article. And then in terms of our external validity, so the fact that this was a multi-center and international study does increase its external validity. However, they did not gather any information based on patients' race or ethnic group. However, it was performed in European centers, leading us to believe that they reported majority of white patient participants. Majority of our patients in this trial were on apixaban. And based on our bleeding outcomes, they may have been higher if majority of patients were on a different anticoagulant, as our apixaban is relatively of low bleed risk comparatively to our other direct oral anticoagulants. Patients in this study were excluded if they had already been receiving therapeutic anticoagulation at baseline, and therefore it is these outcomes cannot just be transferred to that patient population. That would have to be done with care. And our patients at baseline had a low NIHSS score, leading us to be able to extrapolate this data more to that patient population. Another big limitation of this study is that stroke severity was classified based on imaging, which could have been variable between sites, and also limits utilization when we are comparing strokes based on NIHSS score. And then our outcomes were assessed via telephone interviews, which allows risk for interviewer bias, though our interviewers were blinded to the interventions that patients received. And finally, there was limited statistical power to explore subgroups. Therefore, those conclusions cannot be fully extrapolated. However, they may be clinically relevant. So with that, our takeaway being the early initiation of our direct oral anticoagulants in patients with non-valvular atrial fibrillation did demonstrate similar safety and efficacy to later direct oral anticoagulant initiation. And while our recurrent ischemic stroke, systemic embolism, major extracranial bleeding, symptomatic hemorrhage or vascular death appeared to be similar between the two groups, our subgroup analysis did show that our patients that were older, those with higher NIHSS scores, larger infarcts, as well as females in particular, had outcomes that favored that early direct oral anticoagulant initiation. And in these patient populations, I would recommend early DOAC initiation, specifically with apixaban, as that is what was mostly utilized in this specific trial. And here are my references. And at this time, I'd be happy to take any questions, comments, or thoughts.
Hi, Sarah. This is Leslie, your moderator. Sorry, I was a few minutes late. I was in the emergency department. So thank you so much for your presentation. And I have a question myself, and then we'll also entertain any questions that people have in the chat. So my first question for you is on the subgroup analysis, both at 30 days and at 90 days, I was interested to see that it looked like early DOAC was better in the older population, the greater than 70 years of age. What's your takeaway with that? What's your thought about that? Did you have anything you want to share with us about what they found in that age group?
Yes, I also found that interesting. And I think for me, my biggest takeaway was because our primary outcome was a composite outcome. My worry would have been that these patients would have been at higher risk of bleed, and that would likely increase of our primary outcome in this patient population. However, it didn't, which led me to believe that similar to our primary analysis, that the outcomes were similar with regard to bleed. We only saw 2 bleeding events in either group. That really what we're seeing is that these patients need earlier initiation to prevent that ischemic stroke. So I think that these patients are just at higher risk of recurrence of their stroke if the DOAC isn't started early, and that we're really not seeing that higher incidence of bleeding.
Great, thank you. That's kind of what I was thinking too. There's a question from Andy Webb I'm going to read it out for you in the chat. So as you presented, you mentioned intracranial hemorrhage, but then his question is, how did the trial investigators handle if it was minor or petechial hemorrhagic conversion early after the infarct? Did they happen to comment on that?
I'm sorry, just reading both questions. I don't know that they made any sort of specific mention of early hemorrhagic conversion after infarct, or that there was really no mention of the low rate of hemorrhagic conversion overall, except for to say that they thought that bleeding risk was kind of low overall, regardless of the timing of DOAC initiation.
I'll have a follow-up question to what Andy was also saying too, is when they were defining intracranial hemorrhage, and I may have missed this since I came in a few minutes late, did they talk about if it was symptomatic, or do you remember how they actually defined it?
In terms of their intracranial hemorrhage?
Yeah, so if it was, a certain volume on the CT scan, or was the patient symptomatic, did they have any of that sort of definition?
Yeah, so within their primary outcome, it was symptomatic intracranial hemorrhage.
Which I think may kind of answer the petechial part. Maybe if the patient wasn't symptomatic. Then it didn't get identified in that manner. Corinne has a question too. She said almost 40% of patients receive thrombolytics. Was there a subgroup analysis in these patients? So that's the first part of the question. The second part of the question is, do you feel comfortable starting DOACs at or earlier than 48 hours in a patient who received a thrombolytic?
So I was unable to find any information regarding a specific subgroup analysis of patients that did or did not receive thrombolytics. However, I think that because of the large majority, almost nearly half of patients in this study did receive thrombolytics prior to randomization, and we still saw such low bleeding risk that I think though not all patients did receive them, I still think that they were representative of a large enough patient population that I think that this study shows that bleeding risk was still low in that patient population, regardless of whether patients got thrombolytics or not.
The second part of the question, what do you think about if it's early? Would you feel comfortable starting a DOAC earlier than 48 hours in someone who had gotten alteplase or tenecteplase?
I think based on the study, specifically in these subgroup analyses, patient populations, patients that did have a higher NIHSS score or were older, I would argue that yes, this study does show that it is safe, especially just looking at our low incidence of symptomatic intracranial hemorrhage overall, similar between our two groups. I would say yes.
Thank you so much, Sarah. I'm going to give maybe another 30 seconds to see if anyone else has a question that they want to unmute to ask her, or if you want to type in the chat. And I really appreciate your presentation of this trial. I think it's definitely some food for thought for all of us in taking care of these patients and maybe changing some of our thought process and how early we start these agents. So thanks so much, Sarah. And we're going to turn it over to Jennifer. Jennifer, excited to have you here today. And a lot of you all are going to be very familiar with the study that she is presenting because a lot of us took part in it. So it's the nimodipine formulations and administration techniques via enteral feeding tubes in patients with an aneurysmal SAH. And Jennifer is a PGY2 critical care resident at Tufts Medical Center up in Boston. Jennifer, we can see your notes if you maybe want to, perfect, yeah, it looks great. If you want to go ahead and get started.
Absolutely. Can everyone hear and see me all right?
Yes, ma'am.
Perfect. So thank you so much for the introduction. My name is Jennifer Stein. I'm a PGY2 critical care pharmacy resident at Tufts Medical Center in Boston. And today I'll be presenting on the comparison of nimodipine formulations and administration techniques via enteral feeding tubes in patients with aneurysmal subarachnoid hemorrhage, a multi-center retrospective cohort study. So to start off our conversation for today, subarachnoid hemorrhage really is a neurologic emergency that results from blood extravasating into the subarachnoid space. And the leading cause is typically rupture of an intracranial aneurysm in about 80% of cases. The other 20% can result from causes including things like vascular malformations, intracranial arterial dissections, cerebral venous thrombosis, or trauma. And the mortality rate following aneurysmal subarachnoid hemorrhage is about 30 to 50%, but a third of patients can develop debilitating cognitive and functional disabilities. And unlike other stroke subtypes, aneurysmal subarachnoid hemorrhage affects individuals in their working years with a mean age of about 55 years old. And the socioeconomic costs of aneurysmal subarachnoid hemorrhage are quite significant. The inpatient hospital charges in the US are reported to be close to $400,000 per admission and as high as in the $500,000 range for patients who develop delayed cerebral ischemia. So what is delayed cerebral ischemia? It really is the primary complication of aneurysmal subarachnoid hemorrhage and is also a major predictor of poor outcomes in these patients. The formal definition is the occurrence of a focal neurological impairment, such as hemiparesis or aphasia, or cerebral infarction, or a decrease of at least 2 points in a GCS score that cannot be attributed to other causes. And DCI really manifests in a number of ways, some of which include macrovascular dysfunction in the way of vasospasms of our large cerebral arteries, cortical spreading depressions, which are slowly propagating waves of altered brain activity that can lead to an inverted hemodynamic response that can result in changes in vascular response, as well as decreases in neuronal activity, as evidenced by the graph on the right side of the slide. And we do have a medical therapy directed at vasospasms alone, which is where the main topic of our conversation today, nimodipine, comes in. So nimodipine is the only oral calcium channel blocker that's been shown to decrease the rates of delayed cerebral ischemia, as well as improve neurologic outcomes after aneurysmal subarachnoid hemorrhage. The typical dose is 60 milligrams orally every 4 hours times 21 days. And it is mentioned in 2 of our important guidelines for the management of aneurysmal subarachnoid hemorrhage. First, we have our 2023 American Heart Association and American Stroke Association guidelines. And these guidelines make a class 1 level of evidence A recommendation for the use of enteral nimodipine in patients with aneurysmal subarachnoid hemorrhage, and that it can prevent delayed cerebral ischemia as well as improve functional outcomes. Our 2023 Neurocritical Care Society guidelines for aneurysmal subarachnoid hemorrhage also recommend the administration of oral nimodipine in patients with aneurysmal subarachnoid hemorrhage, once again to reduce the incidence of delayed cerebral ischemia and cerebral infarction, as well as to improve functional outcome. And this is also a strong recommendation with a moderate quality of evidence. So formulation-wise, nimodipine is available in a number of enteral formulations. In the US, we have soft gelatin capsules, which are pictured here on the slide, as well as an oral liquid solution, whereas in Canada, there are oral tablets. And in Canadian institutions, for those patients who are unable to swallow tablets, these tablets are typically crushed, suspended in water, and administered via an enteral feeding tube. Although something important to note is that the manufacturer's package insert does recommend against crushing nimodipine tablets. So in US institutions where the soft gelatin capsules are available, the liquid is often extracted from the soft gelatin capsule with a needle and drawn up into an oral syringe, either by nursing staff or by central pharmacy. And in US institutions where an oral liquid product is available, it can directly be administered through the feeding tube. The oral solution is quite expensive, so many hospitals do compound their own oral solution from the gel caps. It is one other thing to be aware of is that the liquid solution does have, the commercially available liquid solution does have quite a bit of polyethylene glycol excipient in it, and this will come into play a bit later in our conversation today. By the looks of our Twitter poll from yesterday evening, it does appear that a majority of institutions utilize the oral solution, followed by capsule liquid extracted by pharmacy, and the lowest frequency of use being capsule extracted by nursing staff at the bedside, as well as crushed tablets. One very important thing to be aware of with nimodipine is the boxed warning to not administer it intravenously or by any other parenteral route. The problem here is that when nimodipine liquid is drawn out of capsules with a needle, it must be done with an IV syringe. And unfortunately, this has led to inadvertent IV administration, which has occurred in the US and has led to the publication of a number of ISMP articles, as this has led to deleterious outcomes in patients, some of which include significant hypotension, cardiovascular collapse, and death. So nurses definitely must be aware that these contents need to be transferred to an oral ENFit syringe that can't be Luer locked to a patient's IV line. And we really should try to minimize bedside extraction as much as possible to help avoid these types of errors from occurring. So to briefly discuss a bit about the pharmacokinetics of nimodipine, mechanism of action-wise, it does act just as all of our calcium channel blockers do. So it inhibits voltage-gated L-type calcium channels to prevent calcium influx into the muscle cells, thereby leading to vasodilation and decreases in blood pressure. And what makes nimodipine special is that it does preferentially act on the cerebral blood vessels due to its lipophilicity and ability to cross the blood-brain barrier. Nimodipine is highly protein bound, extensively metabolized hepatically via CYP3A4, and it does have a relatively low bioavailability ranging from 13 to 16%. Its half-life elimination is 1 to 2 hours, and there is a dose adjustment for patients with cirrhosis. So they'll receive half the dose at 30 milligrams every 4 hours, but still for a 21-day course. Administration-wise, it is recommended to be given 1 hour before or 2 after meals in the US labeling, but without regards to meals in the Canadian labeling, so long as it's administered consistently. And then lastly, nimodipine has to be stored at room temperature and protected from light. because it is light sensitive and subject to photo degradation if it's not administered immediately or stored properly, which is also something to keep in mind as we move through our conversation today. So taking a look at some already published studies that address differences in the varying nimodipine formulations and their administration. First, we have a 1993 pharmacokinetic study by Kumana et al. That included 12 patients with acute subarachnoid hemorrhage. And as you can see, this one patient had a reduced systemic exposure to nimodipine that received it as a crushed tablet via a gastric tube. The authors also concluded that there was limited adsorption to tubing here. And although the authors did state that nimodipine adherence to the tube itself was limited and that the very low oral bioavailability in one very sick patient receiving the crushed tablets via this route may have been a chance finding, this is something to be aware about. Next, we have a 2015 study by Aboud et al. That evaluated 157 blood samples and aimed to characterize serum levels of nimodipine in enteral and parenteral administration from these patients with aneurysmal subarachnoid hemorrhage. And they found that the AUC values were higher in patients who received nimodipine orally versus via a feeding tube. So as you can see, the concentrations are listed on the slide here. Next, we have a 2015 study by Euler et al. That included 28 bedside nurses who extracted nimodipine from gel capsules. And here they compared the number of milligrams drawn up from a simulated bedside extraction versus a pharmacy compounded product. And you can see that bedside extraction provided a lower yield than a pharmacy compounded product, 22.6 versus 30.4 milligrams. And the investigators also evaluated consistency in these two methods. And as you can see, bedside extraction did provide inconsistent results, 75 plus or minus 15.4% of the product being drawn up compared to pharmacy compounding, which was much more consistent and had a much higher yield compared to bedside extraction. And lastly, a 2020 study by Issy et al. Was a retrospective chart review of 85 patients with subarachnoid hemorrhage. And these investigators looked at nimodipine being administered via feeding tube compared to whole tablets. And you can see here that patients who received nimodipine via a feeding tube had increased odds of vasospasm, as well as increased odds of delayed cerebral ischemia. So these are all relatively small studies, but you can see here that the evidence really is sparse and does suggest the need to address this gap in knowledge. So all of this information brings us to the study that I'll be discussing today. And the questions that the investigators aimed to answer was, are there differences in the safety and effectiveness between the various enteral nimodipine formulations and administration techniques? So this was a multi-center retrospective observational cohort study that was conducted across 21 hospitals in North America. The inclusion criteria were patients with non-traumatic subarachnoid hemorrhage that were aged 18 years or older and received nimodipine via an enteral feeding tube for 3 or more days. The exclusion criteria were patients who received enteral nimodipine for less than 72 hours. Our primary endpoints here mainly were our safety endpoints. So the occurrence and duration of diarrhea, as well as the dose reduction or discontinuation of nimodipine secondary to blood pressure reduction or hypotension. Secondary endpoints were ones that were associated with patient outcomes. So here the secondary endpoints were delayed cerebral ischemia, angiographic vasospasm, as well as hospital mortality. And some other endpoints that the authors analyzed included hospital and ICU length of stay, as well as discharge disposition. So our patient groups were stratified, our patients were stratified into 5 main groups corresponding to their nimodipine formulation, as well as their administration technique. So group 1, which included 178 patients, included patients who received liquid from capsules drawn by trained pharmacy staff. Group 2, which included 96 patients, included patients who received liquid drawn from capsules by nurses at the bedside. Group 3 included 127 patients, and these patients were ones who received crushed nimodipine tablets. Group 4 included patients who received the commercially available nimodipine oral liquid product, and there were 252 patients in this group. And lastly, group 5 included patients who received a newly reformulated nimodipine formulation, which, according to the manufacturer, now contains 44% less polyethylene glycol excipient than the original formula. And there were 74 patients in group 5. So taking a look at the statistical analysis that was done in this paper, continuous variables were presented as a median with an interquartile range and were compared using the Kruskal-Wallis test, followed by Dunn's multiple comparison test with Bonferroni correction for multiple comparisons. Categorical variables were presented as a frequency and percentage, or N%, and were compared using the chi-squared or Fisher's exact test. The association between covariates and study endpoints were analyzed using univariate logistic regression, and biologically plausible variables, as well as confounders, which were variables that seem to significantly differ across study groups and or those with p-values of less than 0.2, were controlled for in the multivariate logistic regression models, and an adjusted odds ratio was determined for these. Lastly, the fit of the final models with the variables controlled for in the models was confirmed by using the Hosmer-Lemschau goodness of fit test, and a p-value of less than 0.05 was set at the level of significance for this study. So taking a look at the baseline characteristics of the patients that were included in the study, there were 727 patients included, and generally, almost all of the patients exclusively received one enteral formulation or administration technique of nimodipine. Of note, 7 patients did have crossover between the 2 formulations, but the formulation that they used for a longer period of time was included here. Females comprised 68 of the study population, and the median age was 60. Some intergroup differences included those in weight and body mass index, as well as aneurysm location and aneurysm securing technique. And in addition, there were no differences in Hunt and Hess grade amongst the study population, which is a score utilized to assess the severity and mortality risk associated with an aneurysmal subarachnoid hemorrhage. 109 patients did receive liver microsomal enzyme inducers or CYP inducers, and 12 or 1.7% of patients received inhibitors. 670 patients or 92.2% received any laxatives during their reporting period, and 627 or 86.2% of patients received an antibacterial drug. Lastly, 419 or 57.6% of patients received vasopressors. So now taking a look at the results of the study, of 727 patients, 444 or 61% of patients experienced diarrhea, and the prevalence of diarrhea ranged from 36.2 to 78.4% in the study, so varied amongst the study population. And the highest prevalence was observed in group 5, who received the newly formulated oral liquid at 78.4%, followed by group 4, who received the old liquid formulation at 72.2%. And the lowest prevalence was observed in group 3, which was the group that received crushed nimodipine tablets. Groups 4 and 5 did have a significantly higher number of days of diarrhea compared to the other groups, with a median of 4 days compared to 0 or 1 in all of the others. And when the authors controlled for potential confounders here, groups 4 and 5 did maintain this observed statistical significant difference in diarrhea. Study investigators did also note that these results were not driven by a single center, as most centers within groups 4 and 5 did receive the commercially available liquid formulations. These patients had a higher prevalence of diarrhea compared to other groups. So now taking a look at another one of our outcomes, so dose reduction or discontinuation secondary to hypotension. So nimodipine dose reduction or discontinuation secondary to hypotension was reported in 171 or 23.5% of patients, with group 2 patients who once again were patients who received the liquid drawn at the bedside had the highest prevalence at 41.7%. And when controlling for confounders here, group 2 was still significantly associated with dose reduction and discontinuation. In contrast to our previous findings on the incidence of diarrhea, investigators did comment that the highest prevalence of this outcome was in fact driven by 2 specific centers. And this is important to be aware of since we know firsthand how different practices are in different institutions, specifically within this study that was performed at 21 different centers in multiple countries. So also taking a look at the percentage of vasopressors that were used by these patients, you can see that patients in group 2 also had the highest prevalence of vasopressor use at 71%. So maybe these patients were sicker, maybe these institutions have a lower threshold to decrease nimodipine dosing and initiate vasopressors. These are all important things to keep in mind when analyzing these results. So lastly, our patient-centered secondary endpoints included delayed cerebral ischemia, angiographic vasospasm, and hospital mortality. A total of 225 or 31% of patients experienced delayed cerebral ischemia. And as you can see on the right side of the table, there was a statistically significant difference in delayed cerebral ischemia prevalence amongst the study groups, which I personally thought was one of the more alarming findings of this study. And the highest prevalence was observed in group 3, which were our patients who received crushed tablets, and at 59.1%, followed by group 2, who were patients that received liquid extracted at the bedside at 45.8%. The lowest prevalence was in group 1, and these were patients who received liquid drawn by pharmacy. And after controlling for confounders here, groups 2 and 3 did have the highest adjusted odds ratios. And just like the other outcomes, the authors checked to see if this was driven by a small number of centers, and this was not the case here. With regards to hospital mortality, none of the groups were associated with mortality after controlling for potential confounders. And just to note, the investigators did not end up reporting on the incidence of angiographic vasospasm amongst the groups, as there were noted to be institutional differences in when patients were sent for angiography. And lastly, in terms of hospital and ICU length of stay, patients were in the ICU for a median of 16 days and then the hospital for a median of 21 days. And although these results did show a statistically significant difference amongst groups, the numbers did not actually appear to differ too much from group to group. So when looking at the author's conclusions for this study, enteral nimodipine formulations and administration techniques were associated with the propensity for diarrhea, hypotension, and delayed cerebral ischemia. When taking a look at diarrhea, the prevalence of diarrhea was highest in patients who received nimodipine oral liquid. And once again, this could potentially be due to the polyethylene glycol content in this formulation. And it is important to note that in general, there was a high laxative and antibacterial use in these patient populations, which could predispose patients to developing diarrhea. Although when the authors did control for these outcomes, they did not show to have an effect. In terms of hypotension, the prevalence of dose reduction or discontinuation due to hypotension was highest in patients who had liquid nimodipine drawn up at the bedside. And the authors did note that the exact cause of hypotension in this patient population is unknown, as this was a retrospective study. And this could potentially have been due to institutional practice differences, as well as different thresholds to initiate vasopressors. And it is important to note that these results were driven by 2 sites. Lastly, when taking a look at delayed cerebral ischemia, the highest incidence was seen with nimodipine oral liquid drawn at the bedside, as well as with the crushed tablets. So this does raise concerns about effectiveness of these 2 formulations, and these differences really could be attributed to altered systemic exposure, secondary to inconsistent medication administration, as well as potential differences in bioavailability. So thinking back to our studies from earlier that showed that bedside extraction provided inconsistent and lower yields than pharmacy compounded oral syringes. We also know that the manufacturer warns not to crush tablets, as this has been shown to have a decreased bioavailability in the studies we went over in the background. And also remember that nimodipine is light sensitive and is subject to photodegradation if not given immediately or stored properly. Some limitations of this study included its retrospective nature, as well as its high potential for confounders, the variability of data collection across study centers. And lastly, the authors did not assess for longer term functional outcomes, such as a modified Rankin score. Although our study did assess patient-centered outcomes like diarrhea, hypotension, and delayed cerebral ischemia. Some key takeaway points here. Although the study is limited by its retrospective nature and its inability to control for confounding variables, I do think it is prudent to be aware of the potential differences in nimodipine response based on the different enteral formulations we have available. And based on the results of this study, we should prioritize the use of nimodipine oral liquid, either prepared by the pharmacy department or administered as the commercially available product, as this does appear to be associated with the best patient outcomes, specifically less delayed cerebral ischemia. So these formulations should be utilized and prioritized when possible. Some pharmacist interventions that can be made here include switching to capsules when patients are able to swallow, drawing up liquid in the pharmacy department, as this is a more controlled environment. We know that the intensive care unit is an extremely high stress setting, and it can lead to inaccuracies in capsule extraction, as seen by the studies we discussed previously. And lastly, pharmacists should most definitely educate on the cost differences between the different formulations. As you can see on the slide, a 21-day course of capsules costs about $120 versus a 21-day course of the oral liquid can cost upwards of $11,000. And when possible, we should avoid crushing nimodipine tablets, which unfortunately is not an option for Canadian institutions, as they don't have a commercially available liquid product or capsule available. But a potential solution here would be to create a suspension recipe so that it's compounded in a more controlled environment, such as in the central pharmacy. And that concludes my presentation for today. I'd be happy to take any questions or comments.
Okay, Jennifer, thank you so much. And I'm going to keep the questions fairly short since we're kind of right up along our 1 o'clock stop time. First question was from Andy Webb. Thank you, Andy, for asking this. Was the interaction between holding or dose reducing nimodipine and the risk of DCI assessed by the authors?
I don't recall that it was assessed in the study.
Okay, and then Josephine has several questions, and I'll kind of give them to you one at a time. Are there any interventions that you would suggest for decreasing risk of diarrhea in those receiving enteral nimodipine?
Yeah, I think one of the most useful interventions that can be made in this case is to potentially withhold the use of bowel regimens in these patients, as nimodipine is typically associated with high incidence of diarrhea in general. So as pharmacists, I think one of the biggest interventions we can make is limiting the use of bowel regimen in patients who are experiencing diarrhea.
Yeah, I'd also would add to being careful which enteral nutrition formulation is being used, because some definitely can
Oh, yeah,
contribute to that too. So yeah, great.
absolutely.
Next part of Josephine's questions: from your analysis, can DCI be solely attributed to nimodipine?
Be solely attributed to nimodipine. Not solely to nimodipine itself. Nimodipine is thought to reduce the incidence of delayed cerebral ischemia. And I think this is such a complex disease state, and patients can have so much going on that it really is not just the nimodipine itself, but more so the disease state that can predispose patients to developing delayed cerebral ischemia.
And then the last piece of her question is, are there any pearls that you have for pharmacists who are monitoring drug-drug interactions with nimodipine and other agents that may have an impact on the AUC of nimodipine?
Yeah, absolutely. So as we know, nimodipine is metabolized via CYP3A4. So for any patients that are on an inducer or inhibitor of CYP3A4, I think educating the team on the potential increases or decreases on area under the curve is important. So as a rounding pharmacist on the team, I think we can definitely play a role in educating on those potential drug interactions.
Okay, I think we may have time for this very last question in case you happen to know. Do you know the best use date if it is extracted from the capsule, how long that is good for?
I actually don't know. At my institution, personally, we have the oral liquid syringes available, so we don't typically do capsule extraction here, but if anybody in the audience does do that at their institution and happens to know, I'd love to know, because I don't.
Everybody, thank you so much for attending today. Jennifer and Sarah, thank you for such great presentations. I know Casey would want me to say to continue the conversation on Twitter, because she is our Twitter moderator today for any further discussion. But thank you all again, and hope everybody has a great afternoon.